always want to be cognizant of what kind of complications can occur from what I'm doing. And one of the things is hypotension. So sometimes you're shifting it too much too fast, and just reducing the temp, cooling it off a little bit, will slow things down, and your pressure can come back up. If it doesn't, you slow it down by adjusting the rate. That may or may not help. Elevate their legs. You know, when our blood pressures drop, put those legs up. Let that fluid get back to the heart. And then fluid bolus, 250. Sometimes we pull too much off and we got to put some back. So you can repeat that. We want to put them on oxygen to get good oxygenation going for that cardiac output. And if you just can't get that blood pressure back up, sometimes we have to stop dialysis and, you know, call the healthcare provider or call a rapid response, whatever we need to do. But you go through some things first to try to, you know, the cause of this is that usually because you've pulled too much off or you're going too fast, so we slow it down, give them some fluids back, and if we still are having a problem, then we may have to actually stop the dialysis. What is that? Okay. Okay. Huh. Oh, well. Why are these not talking together? That's weird. All right. So this is the home hemodialysis machine, and it's a little less time, but we're doing it every day, 6 days a week. So rather than being up and down, you know, it stays a little more even as far as your toxins and things like fluids that balance. The problem is you've really got to have a motivated patient who's able to learn this. It's easy as far as there's a red button for stop and a green button for go. But you've got to be able to learn what to do if their blood pressure drops. You've got to have a partner who's willing to help you with this, because you are not going to stick a needle this big in your arm 2 times. And you have to have a very clean home environment, a place to do it, because infection is a big deal. Hemorrhaging is a big deal. So these patients go through some screening before they're allowed to do this. I don't know about insurance. I'm sure these machines are not cheap, and I don't know how much insurance pays for home dialysis. Last time I talked to Ms. Kim, they had 1 patient in this area doing it.
It seems like you wouldn't be able to go nowhere if you do that.
It does, doesn't it? So don't forget, no blood pressures, no sticks, assess through Brew and Drill. We want some range of motion because we want to be able to support that fistula, but we don't need to carry heavy objects or anything that would put any pressure on it. You don't want to sleep on that arm. They don't need to have any decrease of flow in that arm.
So like simple exercises as far as the range of motion goes, like just trying to keep them moving, that's all.
Yeah, just doing simple arm lifts, just things that will keep that muscle okay. Post-dialysis, vital signs and weight are the best things. They can develop any of those symptoms during. Usually I've read that they shouldn't be eating during it, but I know a lot of patients will eat a little bit if they get a headache or nausea. They'll have some crackers there to eat and stuff. Watch for dehydration, sepsis, hemorrhage. Remember the heparinizing can cause them to have hemorrhage. And you have to hold pressure when you decannulate. You have to hold pressure on there to keep them from bleeding. So That disequilibrium syndrome is when we've done this too rapidly and they go through that drop in blood pressure, too rapid a decrease in their electrolytes, their mental status, they'll get very confused. They can have a seizure. And this, we absolutely stop the dialysis at that time, and they may even arrest at this point. So watching and getting, making interventions before we get to this point is important. Why are you not working over here? So weird. So other complications that can occur, cardiac, as I said, immune reactions, hypoglycemia, infection, hemorrhaging, any of that can occur. All right. These patients get poked on a lot. 2 cannulations every time they do this. Questions about hemo? All right, well, let's talk about peritoneal. So, peritoneal is going to work the same way, diffusion. But we don't have to have it a vascular access. We don't have to have a graft or a fistula. We're going to use the abdomen with all that vasculature and the greater and lesser momentum around the abdominal organs. So it's the same thing, the diffusion, the osmosis. We put a catheter in there, we infuse a dialysate, we let it sit, and the vasculature runs through it. It's our dialysis machine, our tummies, basically. And it's removing excess fluids, and then after a prescribed amount of time, you have a lower bag, you open that one up and let it drain. It works on gravity. It's supposed to work on gravity. I don't mind, this is doing something weird. Let's see if it'll back up. And that's gone on together. Okay. There's what I wanted. Ta-da! All right, so we're going to surgically implant a tube, a peritoneal dialysis catheter. Through the sub-Q, we're going to tunnel it down, and it's going to end up in our abdominal wall, in our abdominal space. And again, it works the same way as it did before, osmosis, diffusion. And this can be done daily. Now, we can do it 3 or 4 times a day. When we did it with our acute kidney patients in the ICU, we would do the 4 passes a day. Patients that go home and are doing this at home, a lot of them will get that home machine, get their supper, sit in front of the TV, turn their dialysis on. They'll watch TV, do whatever they want, then they go to bed, and by the next morning, they have been dialyzing all night, and they're done. They dialyze for 12 hours. So they take a break for the next 12 hours, till supper time, bedtime, whatever, get back on it. So they're asleep for a large part of this. So there's a lot of different ways you can do it, but those are 2 ways that are done. So, what do you think the biggest problem with this is? Infection. And I had a student this morning who said she had only seen 4 patients that had this, and every one of them had come in for peritonitis, and it just got worse and worse. But patients do well with this. You have to be very selective. I mean, they have to go through a process of, are they going to be able to keep this clean and understand how to do it? We have, like I said, you can do it by hand here 4 times a day. We have automated machines that can do it. They look like kind of very much similar to that home dialysis machine that's about that big, a little box about this big that you use for peritoneal dialysis. And it cycles all night. And the nice thing about peritoneal, you're not using up vascular space, those vascular accesses, and you're keeping your blood levels more like this instead of, when you dialyze every every other day, your toxins build up, your fluid builds up, and then whoosh, and then it builds up and up, and then whoosh. So it's better for it to stay kind of like this. But some patients don't tolerate the peritoneal. They have repeated bouts of infection, and we have to change them to a regular hemodialysis. Now, this is the dialysis catheter, and there's a little cuff right here, and it takes about 2 weeks, and there'll be a little barrier formed around this insertion site. So that helps prevent infection. You don't want any leakage coming out of here. That's just a breeding ground for bacteria. And then they run it along under the sub-Q for a little ways to help keep bacteria out. We got another cuff here, and then we go into the cavity. So this is helping with decreasing the bacteria, but bacteria can still get in there. And if they continue to have problems with peritonitis, then they have to take it out and go to vascular regular. So, peritonitis. And what are you going to see when you have peritonitis? Rigid abdomen, pain, the effluent coming out will have pus. So you would want to send it for culture. The cloudy, opaque effluent that comes out, it may have a smell to it, it may have pus in it. Connection sites, sometimes the site itself can get infected, and you can put them on a round of antibiotics, unhook it for a while, do some temporary dialysis through a catheter, a Civulon or something, and then let that heal, and you can go back to the peritoneal. One thing that happens, especially right after it's been done, is that you can have referred pain to the shoulder, and that means that you're doing it too quickly, and you need to slow it down. You can warm the dialysate, but do not use a microwave, like a baby bottle. It will get a hot spot. You don't want to be putting that in somebody's abdomen. You can use a heating pad. That'll work. That was something else. If you're doing this in the hospital, you're going to be watching for wetness, watching their respiratory, because you're filling their abdomen up. That's going to press against the diaphragm, which could cause them some breathing issues. Okay, since you're putting this stuff in the abdomen, if you have constipation, that could be a problem, and make it slow down going in there. We don't want to force it in. It needs to run by gravity unless it's on one of the dialysis machines. So you can lift it higher. And when, for the first 2 weeks, remember I said it is creating that barrier, you need to do a sterile dressing change, wear a mask for the first 2 weeks, and then you just clean it aseptically, mild soap and water, no alcohol, no scissors anywhere near that catheter. Because if you cut it, the nurse can fix it to a certain extent, but if it's cut too short, if you accidentally nick it, they might have to go in and replace the whole thing. Nobody's going to be happy about that. And she's going to let you call the doctor. I guarantee. So, what's that dialysate supposed to look like? It shouldn't be brown, because then you might have punctured a piece of colon or something. It should not be bloody. You, right after it's been put in, you may see some little clots come out with your dialysate effluent as it comes out. But it should not be bloody. It should not be real yellow that you may have punctured a bladder. So you just want a rather clear effluent to come out, not pussy, not brown, not dark yellow. And you want to be sure that you are measuring how much you put in so you know how much you're getting out when it comes time, and then weighing the patient. And that again tells you how much. So, a dialysis nurse is kind of a jack of all trades. You will learn everything there is to know about the body, because our kidney failure is going to affect every system. And you work with that patient, as I said, you're going to be like family. And you are going to be the liaison between the nutritionist, the social worker, the doctor, their regular doctor, their dialysis doctor, their kidney doctor. I mean, you are the center of all of that with the patient. So it's a great job. It can be a little, you have to get used to the kind of patient that is a chronic illness, and sometimes that becomes difficult to deal with patients that have chronic illness, because these patients aren't going to get better. But when they get that transplant to take care of themselves, they will do better. So let's talk about that transplant. Dialysis saves their life until they can get a transplant. But the transplant is where they're going to end up. Okay? You have to maintain, you have to be in good hemodynamic, you have to be able to go through surgery, let's put it that way. You have to be stable enough that you can make it live through a surgery like this. Because the surgery takes 3 or 4 hours, both the taking out of the donor and putting it in the new patient. They leave the old kidney in there unless there's an infection, and it generally will just shrivel up and be nothing. They do have to do matches for HLA antigens, because you will always, this is a foreign object you're putting in there. You want to get it to as close a match as possible. You would think that would be a relative, but it isn't always. And just because you find a really close match, they still have to take immunosuppressive drugs after this and continue to do that. Post-operatively, the donors can be live, can be a cadaver, can be a relative, cannot be a relative. They match those antigens. So, of course, we got to watch for urine output. We got to be sure those kidneys are working. Sometimes we have to give a little fluid challenge to the new kidney and say, okay, come on, let's go, and get going. But we always are assessing that hourly output, because if it were to drop 1 hour, it could be a sign that they're having some rejection, hyperacute rejection. The bladder irrigation is going to diminish the bleeding and remove any clots, just like we did with the other irrigation we did in the bladder. We want to get that catheter and that stopped as soon as we can. Our most common problem, though, is rejection. So let's talk about the 3 types of rejection. There is hyperacute. When I think about that, I think about, I just got given a new house. And I walked in there and looked around, and I didn't like the colors of it. I didn't like the furniture. I didn't like where it was. I just, no, this is not going to work for me. I start banging on the door. Let me out, let me out. That's an immediate reaction I have. Within that 48 hours after that kidney gets in there, it just never really liked it there. And it starts acting up from the very beginning. You're going to have high fevers. You're going to have tenderness at the graft site. And those patients have to have those kidneys removed. or that kidney. Unfortunately, nobody else can have it. They're back on dialysis, waiting for another kidney. Now, there is something called acute. So that was hyperacute. I didn't like it. I want out now. Acute, I stayed there, got used to it. Got a little upset, wanted a pool, raised a little hell over that, and they gave me a pool. I stayed there a little longer. So I'm good, except every now and then I find something I don't want, and I'll start acting out. And once I get it, I'm okay. So with this kidney, I start having flank pain. I might have a little temperature. My BU and creatinine might start to go up. What do I do about it? For acute rejection, you increase their immunosuppressants. And they say, oh, okay, I'm good now. Sorry, didn't mean it. I'm good. That can go on for a couple of years. If you keep having rejection and eventually it becomes chronic, where you are always in a state of this kidney's not really working like it ought to be. They're always running away and banging on the door and upset. And you will get back with chronic. This occurs over months to years. It's just like you started all over at stage 3 and you just went on down and lost that kidney again. So chronic is over many years, and they will end up back on dialysis and back on the transplant list. So, and it's not unusual, it's not uncommon for patients to have more than one transplant. Go through one, do okay for a couple of years, and then they end up with chronic, have to go back on dialysis, get back on the transplant list. Or maybe they had a hyperacute where they didn't even keep it for 2 days. They're still in their day of surgery post-op day 1. Okay? So these patients will always be concerned about rejection and always on immunosuppressive drugs. So it is a constant chronic disease process that you really have to learn self-management. They can have had a delay in harvesting and have some ischemia, end up with a little AKI, need to go on dialysis temporarily, and then do fine. They can develop thrombosis of a major vessel, which is going to occur over 2 to 3 days, and you're going to see a drop in their output. And the same thing with a renal artery stenosis. Kidneys aren't getting perfused. Treat it like an AKI because their blood pressure goes up. And you go in there and dilate, do whatever you need to get that kidney working again. As I said, they're on drugs, corticosteroids, an anti-lymphocytic preparation that suppresses their immune system, so they have a much higher risk of infection, viral, fungal, bacterial. During this COVID, we have not been able to go to any of the units with students because of that. Questions? Okie doke. I want to do the UTI Urosepsis case study now. Anybody look at it? Yes? Yay! Awesome. All right. So let's look at this lady and look at her in respect to those. Remember in documentation, we've got those 5 questions we ask, and we look at relevant stuff, and we figure out our priorities today. So this lady is a 75-year-old woman. She's widowed, lives alone in assisted living. She's been feeling fatigued for the last 3 days and has a fever of 99.2. She tells the nurse she has had painful burning sensation when she urinates, as well as some incontinence in the last week. The RN takes some vital signs, and there they are. No work of breathing. Heart rate 90, SATs 97 on room air. So, does anything make your spidey senses go off that you might need to call the doctor?
Yes.
Yeah, so Alyssa, tell me what it is. What's relevant about this? Alyssa, you don't want, isn't that your name?
No. Miss Whitaker, I'm Amber.
Oh, for God's sake.
And I would never know you put a list on there. She would have said.
Well, I guess Alyssa is here in absence. Amber, are you in my, what AD group are you in?
8.
Oh, hey. You're not going to Enterprise.
No, don't take me for Enterprise.
You're going with Miss,
So,
Sullivan.
Yeah, that's what she was. We was confused because I was like.
Yeah, I was
6 is going
confused.
to
I'm
medical,
sorry.
and I'm 8.
I don't have a card for you, so I just like, oh, here's a card I don't have. Okay, that just doesn't. The name did not fit you, but all I had, so I went with it. She's a key. Amber. So where's her buddies? Where's 8? Yeah, y'all are
Yeah, I
going.
was wondering. I was like, so you split me.
Where did I tell y'all were going?
Four
Flowers.
north.
Flowers on what?
4 north.
4 north. Okay. There you go.
So,
So, what are you going to say to the doc when you call?
I know you would. She's a widow and she lives alone. That's a problem. And
Okay.
she's elderly. And then she's having dysuria.
Okay, but first you're going to say, hey, Dr. Whitaker, this is
You would
Amber.
and then you would explain about the patient.
And I'm calling about Alice Kelly. She's 75, widowed, lives at the assisted living.
And
That's
then-
your background situation.
Yep.
Okay, go ahead. What did you assess on her, please?
That she's had fatigue in the last 3 days with a fever of 99.2, which could be she'd have a sign of infection. And then she's had painful burning sensation while she urinates. And then she had some incontinence. Her
Okay, so
sign
what
was
you want to
fine.
do?
I know you want to try to get her to urinate in the cup so you can get a specimen.
Okay, is that how you're going to tell the physician? You're talking to the physician.
I guess just ask the physician, can we do a urine?
I'd like to
culture
do a UA. Would you like some
Yes,
blood work
yes.
also? Okay, all right. So you're going to use that S-bar, tell him who you are, who your patient is, what's been going on, why you're calling, and that when you assessed her, you found she had painful burning with her urination. She's had some incontinence. Her vitals look good. Her SATs are okay, but you think she might be getting a UTI. Can we check her urine and maybe do some blood work for a WBC? Okay? So it comes back. Jay, what's relevant up here? Come on, Jay, look at those.
I'm looking.
What do you
Okay.
see in that white blood cell
I'm
count?
gonna say the hemoglobin.
Is
Normal. White blood cells elevated.
Okay, well, white blood cells. Yeah, white blood cells.
this is written weird.
okay, how about those neutrophils? This one gave you the norms.
Yes,
Elevated.
it's elevated.
It's elevated a little bit. How about the UA?
The urine is cloudy.
It's positive for nitrates and loop, which is infection. It also
Okay.
has red blood cells in it.
Okay. So, our doctor ordered macrodantin, peridium, and Bactrim. What am I gonna teach her about macrodantin? Why does she need that? What's it gonna do for her?
That's an overall antibiotic that helps them until we get back to the culture and sensitivity to see what it could treat.
So it's not really a systemic antibiotic, Elena?
It's the bacteria from the bladder.
Bacteria what?
From the bladder, it cleanses the bacteria.
Yeah, remember, that's the one that just stays right here in the GU system. Doesn't get systemic. It's not a bacterial cycle. Doesn't kill anything, but it helps to clean that bacteria that's trying to be in there. You might see it being used at a nursing home if somebody's colonized. She's not having a lot of symptoms, but let's see if we can't get rid of the bacteria. Don't want to give her an antibiotic because we don't want her to develop resistance. All right, so Haley, tell me about the peridium.
Isn't that the one that makes you pee orange?
She is going to pee orange. What's it do for
Probably
her?
know that. She'll freak out if she didn't know it's supposed to do that.
Yeah. What does,
It's gonna help with the pain.
yeah, good, good. Amber, what about, is that right?
Yes, sir.
What's you laughing? Tell me about the Bactrim.
I don't know, cause it's funny because I was like, I just knew she was gonna call on me quick.
Quan, tell Amber about the Bactrim.
It's a sulfur, I'm trying to pronounce this.
So Venezuela, whatever.
Yeah, SNZ, yeah. What kind of drug is it?
And
Classification.
it's the antibiotic.
It's an antibiotic. What's special that we need to teach people about that drug?
Take it like you're supposed to, don't take it just because you feel better.
If it causes itch and stop,
They see
Full
that
glass
rash.
of water, because it can cause little stones. It can crystallize.
Speaking of water, with that, the macrodantin, we can take that one with milk, right?
Yes, if you're having
If-
GI
yeah.
issues with it. All right, so 2 days later, we go in to check on her, and we find that she doesn't know what day or time it is. She's unable to get off the couch. She's mentally alert, and she doesn't have a history of confusion. Samantha, what data is relevant there? What's bothering you?
She doesn't know what day or time it is.
She doesn't know what day and time it is. So why would that bother you?
Because it could be increased confusion, meaning her UTI's gotten worse.
Okay, because we might have gotten a UTI worse because she doesn't have a diagnosis of this. She can't get off the couch. So Michelle, what jumps out at you now?
You got the white blood cells, neutrophils, potassium.
What about the potassium?
That's
No, never mind.
Okay, that's all right.
Heart rate is increased. Temp is definitely increased.
All right, we got a heart rate and a temp. How's her satin blood pressure?
That's okay. Blood pressure is a little bit elevated for her.
Okay, but it's okay.
Yeah.
I can't remember what it was the first time. So, we hadn't talked about a lactate, but her creatinine's a little on the high side, high normal. Well, actually, it's high. But a lactate, does anybody know what that is telling me?
Infections, anything over 2,
Not infection, but sepsis. It's telling me acidosis. Lactic acid or acidosis, and that occurs in sepsis. And a lactate, anytime it starts creeping up above 2, and hers is 2.4, that is cause for concern if that patient has some type of underlying infection. Because we would be worried. Her white count is trending up, her neutrophils are trending up, and Now we have lactate at 2.4. So what do you think's going on here? Her heart rate is also tachycardic. What's going on? Is the Bactrim working? No. So now what are you going to ask the physician to do?
Well, if you already did the vacuum, you should have done the culture.
Check those cultures, see if we can give her something else. He'll probably admit her. And on assessment on admission, 12 hours later, she's restless and anxious. She remains confused, but her breath sounds are fine. Her S1, S2 are fine, no edema. Pulses are good, abdomen soft and good. She has 50 cc's of urine in the last 4 hours. There's her vital signs. What's concerning? Naima.
She's only had 50 cc's of urine.
All right, she's getting oliguric.
Her temperature has increased, her respiratory rate has increased, her heart rate has increased, and her blood pressure is down.
Okay. And look at her SAT. Her SAT has gone down too. So let's talk about why. Her temp has gone from 102 to 108, 102.8. This won't work in here for some reason. So it's going up. My heart rate has gone up to 122. Why would that be?
Because the blood pressure is decreasing.
Okay.
So
And her blood pressure of 88/50 tells me I'm not getting perfusion. So my heart rate is going to try to compensate for that and try to get more cardiac output out there. Okay, good, Juan. How about that respiratory rate? It's gone up, but my SATs are going down. What is she trying to do with that? Trying to blow off this lactic acid. We need another lactic acid, lactate. We need to see what's going on with her breathing, and is she getting metabolic acidosis? And now it's all the way up to 4.5. This is classic sepsis, okay? She has quit peeing. Her potassium now is elevated to 5.9. Her white count's up. Her neutrophils are way up. Her creatinine has gone up. So, what do we need to do? Well, let's look. Let's see what this next one is. Her primary problem is sepsis. And when you get sepsis, that's an infection that your body goes wild over. It has a massive inflammatory response and goes into what's called SIRS, Systemic Inflammatory Response Syndrome, where it vasodilates, you get a massive volume increase, and then, but you have a diminished cardiac output. So if we go back there and look at, let's do the next one. Okay, let's go back here and look. Trying to find the blood pressure. Here we go. So this tells me that my cardiac output's low, right? Her breath sounds were clear. I'm not fluid overloaded there. So what do I need to do to fix this? Fluid resuscitation here. Because that SIRS reaction takes that fluid out of the vascular system. And she gets fluid volume deficit, and you will start seeing changes in level of consciousness. They're going into metabolic acidosis, so you're going to see Kussmaul breathing. So you need to get oxygen. You need to get fluid resuscitation going. So what is your priority? Aggressive fluid and volume resuscitation to restore that cardiac output. That makes sense? Okay. Now, we had 5 questions on the other thing, and this goes on to look at the rest of things. What interventions, this was one of your questions that you wanted to do. What are you gonna do for your patient? Well, what do we need to do for this patient today? Well, why do we need a second IV?
To get fluids in faster.
To get those fluids in faster. We gotta change that antibiotic, so I don't wanna have to stop anything. Second IV will let me get those fluids in faster, get that antibiotic in, bolus them, fluid resuscitation, and then let's check those lab works and see where we're going. So priority systems, cardiac, to keep up with her cardiac output. Respiratory, let's be sure we don't overload her. Neuro, confusion is occurring. We want that to get better. And renal, we need to see her start peeing. Those are the outcomes we're looking for. What's the worst possible thing that can happen? Well, with sepsis and SARS, the next thing that's going to happen is MODS, or multi-organ dysfunction syndrome, where all the organs in your body start shutting down. And that's pretty bad because most of these people have very high mortality rates if they get to that part. So we knew way back when we said, I think we need to admit her because this antibiotic isn't working, she's getting acidotic, her respiratory rate is up. So we were on top of it, and we got all that fluid resuscitation, everything done quickly, so that now we're monitoring these vital signs, and we hope to see the blood pressure go up and the heart rate come down. Her labs, we want to see get better. She needs to get more conscious, and with it, less confusion, and we keep watching those trends. But because we were watching trends, and because we knew where we could end up bad, we fixed her before she got there. Okay? So don't forget, your patient's going to be scared, especially when she gets back with it. And sometimes we get so caught up in trying to do our thing, we forget about the patient. And these are those 12 steps. What data is relevant? What are the rationale for my orders? What are relevant labs? What's my primary problem? What's the patho behind it? If you know the patho, then you'll understand when we try to start fixing it. You should always know, why am I giving 250 cc's of normal saline in a bolus right now? It's not because the doctor told me to. It's because you're trying to get that cardiac output up. Okay? Nursing interventions, NY, priority body systems. What can go wrong and what do I need to be assessing? What systems are going to be the most important for me with this big problem? And that way I'm ready for it. And if it does happen, boom, we're on it. I had a student who had a patient in AFib. They had just started anticoagulating. And we had talked that morning about the possibility of PE or DVTs. He had a PE about 2 hours into the shift. And she knew exactly what was going on. He started getting anxious. She checked vital signs, she got a SAT, and she called rapid response. And he ended up having a PE. So because we had talked about it, she knew what to do and what to be looking for. And that's what you want when you're on the floor. All right. I got another case study, but I am obviously not going to be able to have time to finish it. I'm only going to get through the next chapter. So this morning I told them they could stay after class and we'd have a little study group, and everybody was kind of done. So I will post the answers to the other case study, but I'm not going to do it for a couple of days. I want you to look at it and go through it. It's on acute kidney injury, I believe. So this is the last chapter. It's day 3, I think. And we're going to talk about problems that men are unique for the male population. Yeah, because they are different in a few ways, okay? So let's look at some of the things that make it distinctive. Well, we're still going to be doing elimination, cellular regulation, infection, sexuality, and reproduction are also interrelated concepts because some of these diseases do cause erectile dysfunction, incontinence, and infertility. The first one we're going to look at is BPH, which most people say benign prostatic hypertrophy. It's actually hyperplasia. Hyperplasia means that the cells are actually reproducing. Hypertrophy just means it gets bigger. But either way, you want to look at it. This is a prostate, which is around the urethra. And because it grows inward, it cuts off flow. So the first symptoms we're going to see have to do with flow. They're going to have problems starting the stream. They're going to have a weak stream, those kind of things, because it grows inward and blocks the flow. Now, there are modifiable and unmodifiable risks. Race, genetics, family history, history of cancer. I think it was prostate cancer that if your the genetic testing they do for breast cancer, the BRCA testing, if it's positive, then that leads your son to have a higher incidence of prostate cancer. Thank you. Obviously, I won't test you on that because I'm not 100% positive. But modifiable risk, obesity, metabolic syndrome increases, beverage consumption. So 40 to 50% of men between the ages of 50 and 60 have some prostate issues. When you get to be 80 years old, over 80% of those men have it. If you live long enough and you're a guy, you're probably going to have some prostate issues. I didn't say prostate cancer. Prostate issues. So it's very common. And if we can address some of those modifiable things, that can help. But when we look at assessment, they're going to have frequency, urgency, nocturia. They're going to be getting up at night a lot to go pee. What usually gets them to the doctor is that hematuria. They'll have some blood in their urine. And we know that can mean bad things. So they usually will get them, or it's just becoming a problem in their lives. They have increased chances of UTIs. They usually have some urinary retention. Their streams aren't good. And just their pattern of their voiding pattern changes. They have trouble getting it started. They feel like they never get their bladder quite empty enough. Okay? But it's usually that blood in the urine that will get somebody in. So we want to look at their history. Do they have increased risk? Do a physical assessment. And what we're looking for on this, as I said, BPH is common. But prostate cancer presents kind of in the same way. So we have to rule that out. How do we do that? Blood. Check a PSA level. And the other thing we do is a rectal exam, a digital rectal exam. Because of where that prostate is, that is the best way to feel and see, how the prostate feels. Is it spongy and elastic, or is there some type of hard nodule in it? Because that hard nodule means cancer. Okay? So we've checked our little guy out and he's good. No cancer there. We just got some BPH. We're going to look at a urinalysis to see if he's got an infection. We're going to see how his white count is. We're going to check his red count and H&H because if he's having enough bleeding, that can go down. He can get anemic. We want to see how his kidneys are working. So BU and creatinine. And then the PSA, if we think that it could be cancer, he'll have a biopsy done. And we'll talk about that when we get to the cancer part. So, how do we help this fella? Well, we want to teach him some things like not having a lot of fluids right before you go to bed. Cut out the coffee, the diuretic drinks, alcohol. anything, look at their medicine list. Anticholinergics can cause them to retain urine and make the problem worse. There are herbal remedies. Be sure, ask him if he's on anything else, because something like saw palmetto can interfere if they're on any type of anticoagulant. Frequent sexual intercourse can help it releases prostatic fluids, and that can help relieve some of the obstruction. And if there's any type of clotting in the prostate artery, you may have to go in there and do a stent or do some kind of cleaning out there, de-embolize that area. So there are some non-surgical type interventions we can do, and we also have drug therapy. And we'll talk about those in just a minute. The surgical management, we have minimally invasive ones, and we have our gold standard TURP, where we do a cystoscope and remove pieces of that prostate so that it's not causing obstruction anymore. So, we want to talk to them about toileting when the urge comes. Remind them, to keep clean and dry. If they're having incontinence, which is not uncommon, to use pads and things, but when it becomes a big enough problem, then we got to move to some drug therapy. There are 2 different drugs. One of them, the finasteride, actually shrinks that gland. It diminishes the hormone which caused the prostate to grow in the first place. So we're going to block it, and now the prostate will shrink and get smaller. That takes several months though, and we don't always want to wait that long. So a lot of times they'll start them on the tamsulosin, which is actually a vasodilator. Okay, so it helps to increase the flow, and it works much quicker. The finasteride can have side effects of erectile dysfunction or decreased libido. They need to wear gloves when giving the tamsulosin, because it does relax and it can cause vasodilation with you. You want to watch for orthostatic hypotension for that, and find out if they take ED drugs, because the combination of the 2 can drop their blood pressure. Hi, we've got about 15 more minutes. Cool. Okay, thank you. Other procedures actually shrink the tissue. The tuna or the microwave one destroys excess tissue. These are less invasive. They have, you don't have to, they can sometimes be done in-house, outpatient surgery, or even at the doctor's office. They require less catheter time, and they have less side effects that occur from them. So a TURP actually goes in and with a cystoscope and relieves the obstruction through either shaving off pieces of the prostate or putting small slits into the prostate. And post-op, after this surgery, they will have a catheter. They will feel like they need to void, because this isn't your common everyday catheter. This is a big catheter, like a 12 maybe, and it has a bigger balloon. Instead of that 5 to 10 cc's, it's 35 to 40. So when you inflate that, you put a little tension on it and take the catheter to the abdomen, and that is to help prevent bleeding at the op site, and also for the irrigation that we're going to be set up to do. So they're going to feel like they need to pee. You don't want them to be pushing against it. Just tell them that you have a catheter, it's voiding for you. but you may have to use a muscle relaxant like Bentyl to help the spasms that occur because that catheter is big. So the other thing different about it is it has 3 ports here. One port is for that big balloon. One port is for putting stuff in. You're going to have an isotonic solution of normal saline that's going to flow into the bladder. And then it's going to come around and come out this tube, this port, into a catheter, drainage bag. And it's called continuous bladder irrigation. And you are going to have an order to use CBI to keep urine clear. So you got control of that roller clamp. You can increase it or decrease it depending on your assessment. So let's talk about when to do what. So your patient, what we're trying to do with this, it's a cool solution, so we're trying to vasoconstrict, decrease bleeding, and also, usually they have a lot of clots and things after you've been screwing around in there and cutting and moving stuff. So we're trying to keep those clots from clogging up that catheter. Because if it gets clogged up, then the bladder gets full of urine and starts to expand. You got pressure on the site and pressure on the belly and pressure on the patient. Nobody's happy. So when they first come back from surgery, the rate's usually around 250. I mean, you got a big 3-liter bag there. And you're going to be checking every hour to be sure that if you're putting 250 cc's of fluid into that bladder, I got at least that much or more coming out. Otherwise, I'm filling that bladder with saline. So every hour, you're going to look and see how much did I put in, how much do I have in the bag coming out. Okay? Someplace, and after the first 4 hours, that can stretch out a little bit. It just depends on the patient. But you always want to know that you are getting out as much as you're putting, more than you're putting in. Okay? If I go in there, and the patient's been on CBI at 250 an hour for the last 2 hours, and I go in there and I got 800 cc's of fluid in my bag. How much urine? 300. I subtract what I put in from what I'm taking out. I got 300. Awesome. The urine looks pretty clear. I don't see a lot of clots. So I'll slow it down. I'll slow it down about 200. Okay. So I come back 2 hours later, and now I have been putting it in, and I look at my bag, and I've only got 200 cc's of fluid in that bag. Got a problem? Yeah, I put 400 in there. So I'm short. Where's the rest of it? That means that I probably got a clot or a kink or something's going on. So what is the very first thing I would do?
Check for kinks first.
Okay, I'm working my way back. I would turn it off first.
Oh, yeah, stop.
Yeah. Don't put anything else in there. Then I'm going to assess and see if I have swelling, bladder's getting full. Does he have any pain? He'll probably say yes. And get him to turn, because sometimes they just lay on the catheter, they'll turn and get on it, like she said, get a kink, and the minute you get them off of it, whoosh, all the urine comes out. And if that whoosh happens, then I have 600 of fluid coming out, then I'm good. Put 400 in, got 600 out, I got 200 of urine. Over 2 hours, we're good. But if it doesn't, then I can irrigate. All these fluids have standing orders, depending on the physician. You can do it 2 or 3 times. Use about 50 cc's of normal saline. This is a sterile procedure. I know that you will see a little irrigation kit sitting on the bedside with a piston tip syringe in there, probably being used over and over. But are you confident that nobody fooled with that while you were gone? I'm not. I'm going to get me a new kit every time. that I have to do that. And I'm gonna sterilely, with my nice gloves, gently push 50 cc's of fluid into that catheter. Then I'm gonna hook it back up, and I'm gonna hope to see the whoosh and everything come out. If I don't, then I'm gonna do it again. And if they gave me 3 times to do it, I'll do it again. Usually you can dislodge the clot. Usually there's a clot sitting at the tip of the catheter here, or somewhere. It's just, if you get it out. But if you don't, then you have to call the physician. Okay? So if I come back, I got it out and I come back, and now I see the urine has gotten to be ketchup-y looking. What now? Is that a problem? Yeah, they're hemorrhaging. So now I'm going to turn that thing wide open because I want to vasoconstrict, and I'm going to call the physician because they're hemorrhaging out. That's a problem. Pressure is probably going to drop, so their legs are going up. I'm going to get ready to give fluid resuscitation, and he may even end up back in surgery. Okay? So, we don't want leakage around the catheter. That could mean there's a clot, and we might need to irrigate, especially if we don't have as much coming out as we put in. Red tinge, if that urine is looking darker pink or has a lot of clots in it, we want to increase the CBI because we want to clear that up. If we have less coming out than we have going in, the first thing we do is clamp, turn off the irrigation. Then we check for kinks, obstructions, irrigate, and if we can't clear it, then we notify the physician. Post-cath, they need to increase their fluids. Don't forget education when we take catheters out. They may feel some burning the first time they pee, but that should go away. We would hope they're voiding well before they go home. But sometimes incontinence is a problem, and these patients may end up, or retention, they may end up going home with a catheter. So then we've got to educate on that. All right, so we've got our little TURP. We know what that is. Big thing is the CBI afterwards. We're maintaining that catheter patent. We are treating for bladder spasms, pain control, avoid straining. They're going to be getting probably a stool softener because we don't want to put any pressure on that incision. And complications. All right, let's look at that prostate cancer. Notice it's sitting up here. It's on the outside. So it's really not obstructing anything, but a lot of times they'll have a little BPH tube, and they'll usually end up coming in because they've got got a little blood in their urine or something. If they have a family history or at high risk, they'll start doing routine PSAs. That number changes. The last time I looked, it had just changed again, so I'm not going to worry about telling y'all that. But most of these are very slow growing. And sometimes we don't do anything with them except watch. So let's talk about some of the increases in chances of having first-degree relatives. African American men have more prostate cancer, have an increased incidence. We need to be eating more fruits and vegetables and less of that nice grilled meat that I love. I don't have to worry about prostate cancer, but my husband does. So it is the second most common invasive cancer, but it is the slowest growing malignancy. Now, I said that, but there are some very aggressive prostate cancers. They are the more rare types, but I have seen them, and it is like, all right, surgery tomorrow, and surgery the next week. It is very quick. We got to do something. But a lot of times, prostates grow very slowly, and it may be a matter of, let's just wait and see how this goes. they may not be good surgical candidates, or we may need to bump them up a little bit before we do surgery. And they'll have them back 6 months later to see what's that PSA done, what has, what's the size, what's going on with it, is it growing? So, the prognosis is generally pretty good for prostate cancers. 95% of them are adenocarcinomas, and we usually can get those out pretty easily, and they not have any more problems with this. But the assessment for this is that digital rectal exam and a PSA along with a phosphatase will also increase with cancer. So the DRE along with the PSA is the most effective way to look at it. But if we suspect something, then they're going to have a biopsy, okay? They're going to use a transrectal ultrasound to find it and go up and biopsy. And if it is, also, if it comes back positive, then we're going to work them up for metastasis. They're going to get an MRI, they're going to get a CT scan and a bone scan, and be sure it hasn't metastasized anywhere. And then we'll make a decision about what we want to do. Post-care, for these are usually done outpatient, and the patient needs to understand when to call. If they can't pee, they need to call within 8 hours. If they start having signs of an infection, chills, blood in the urine, persistent pain, all of that, they need to call. You want them to increase their fluids, limit the activity for the first 24 hours, but after that, they should be able to start getting back into their normal routine and wait for that biopsy to come back. If it could come back negative, then we're good, and they'll check another PSA probably within 6 months to a year, depending on the physician. It could come back positive, but very slow growing. So let's check and see what's going on next 6 months from now. Or it could come back aggressive, and then we're going to look. If it comes back positive in any way, they will start looking for metastasis. If there is or isn't it, that will determine how we want to treat it. But if you've got an 83-year-old gentleman who's got a very slow growing prostate cancer, he's going to die from something else before he dies of that prostate cancer. If it's a very small, not aggressive tumor. Just depends on how early you get it. Radiation treatments can be done to help it get smaller as an adjunct to a prostatectomy. Hormonal therapy will decrease the amount of testosterone. It's like putting a man into menopause. So they're going to have hot flashes. They could develop incontinence or ED from using these, but what they do is stimulate the luteinizing hormone to produce the testosterone, and they use it up real fast. So they get rid of all the testosterone because the cancers usually are testosterone positive. If they do that, they are also at increased risk of bone osteoporosis, and we have meds that we use to decrease the risk of breakage with that. Chemo is used usually for metastasis if they develop metastasis. Surgically, a bilateral orchiectomy, a laparoscopic radical prostatectomy, or a radical prostatectomy. The laparoscopic will use robotic assistance, and it's used for smaller tumors, less than PSA of less than 10. They will have decreased cath time, decreased complications, they recover faster, but it has to be a very small tumor in order to do that. Post-op, a radical prostatectomy is going to go in there and get everything, and it's usually done retropubically, and they remove the whole prostate gland, the capsule, the cuff, the bladder neck, the seminal vesicles, the regional lymph nodes, and then the urethra, urethra is anastomosed to the bladder neck. So CBI afterwards, keep clots and bleeding down, but we do get these people up and walking post-op day 1. We are working on hydration, care of the wounds, they can have drains, and then of course any post-operative complications normal. They can elevate scrotum on a pillow for swelling, because that's a common problem. And urinary incontinence and erectile dysfunction are also two very common, pretty common problems that can occur. Not so much erectile dysfunction, because the procedures have improved tremendously, and they now do a lot of nerve-sparing procedures that don't affect that nerve. But incontinence is not uncommon. I had a friend that went through this and had a procedure. It was fairly new at the time, and I can't remember what they called it, because we just called it the button. And he had a little button in his lower abdomen. When his bladder filled, he pushed that button, it'd let him go pee, and then he'd push it again and it would close it on. Must have been sitting at the sphincter. Worked great, except he got a bad UTI and they had to take it out because it was a little foreign thing in there. But he did eventually get his continence back. It took another 6 months of Kegels and really working with it, but he did get continence back with that. All right, I'm going to let y'all read about testicular cancer. I think my time is, yeah. And erectile dysfunction, I just want to say this all has to do with flow. There's 2 types. One of them can be brought on by stress. And you ask the patient and do an assessment and say, do you still have morning erections? Because that means that the blood flow is still good. You can do perfusion tests, and that's usually the problem. Patients with diabetes, patients with sickle cell, common problem for them to develop. And our medications that we use for this, they're on our list. I'm going to let y'all look them up. But know that they work by increasing flow. So they vasodilate. And if you have a patient coming into the emergency room with chest pain, and you give them nitroglycerin, what does that do? Vasodilates. And they had an ED drug the night before, or maybe a couple hours before. They can bottom out their blood pressure. So they always ask that question. And I'll let Dr. Daniels show you our video. I use it usually before her, but we don't have a lot of time. So there are lots of different ways to address the problem. Vasectomies are the last thing. No scalpel, local anesthetic. The big thing I want to stress with vasectomies, come on in, is that they need to have birth control or not have sex for at least 3 months and report back to that doctor, because there are some strong swimmers out there that hang around. My next door neighbor, I've lived in my house now for 14 years. 6 months after I moved in, she was pregnant. And I remembered when I moved in, they had been gone for a vasectomy. I'm like, huh, yeah. He did not go back and have a check. And they have 2 beautiful 15-year-old twins. Oh. Not only did she get pregnant, but she had twins.
Oh, Jesus.
So stress to your patients that checkup appointment is very important. And no fooling around until then. These are the other conditions. I'm not real heavy. I just like you to know what they are. There's a chart. You can look through those and just kind of understand what they are. Questions? That's somebody's phone up here. Nope.
Like somebody's alarm?
Kim? All right. So please work on that other case study. If you're an 88, just hang out here for just a second.
Just a second.
And work on that case study. I'm not going to post the answers for a couple of days, maybe the weekend. So see what you can do with it. And if y'all don't have any questions, I'm done with everybody but 88.
Yeah.
Now,